Respiratory module, part 2, audio 4. Large cell anaplastic carcinoma. This is undifferentiated malignant epithelial tumor that lacks the cytological feature of small cell carcinoma, squamous cell carcinoma, or adenocarcinoma. The cells have large nuclei, prominent nucleoli, moderate amount of cytoplasm. Sometimes giant cells may be seen. Tumors highly malignant tend to be peripheral in location. In this type of carcinoma, the malignant cell looks anaplastic, and there is no cytological feature of small cell carcinoma, which will be discussed in next slides, neither of squamous cell carcinoma, as keratin pearls and intercellular bridges, or the glandular differentiation and the acini that characterized of adenocarcinoma. This is the macroscopical view of large cell anaplastic carcinoma of the lung. So we diagnose large cell anaplastic carcinoma by exclusion of the other types. We have to take the biopsy, tissue biopsy, and the tissue biopsy should undergo and submitted to the various immune histochemical stain to differentiate squamous cell carcinoma or adenocarcinoma or small cell carcinoma. If we exclude all those types, then the diagnosis of large cell anaplastic carcinoma would be preferred. This is also another picture of large cell anaplastic carcinoma of the lung. Look at the cell. They are large, with large nuclei, prominent nucleoli, atypical anaplastic looking of the malignant cell. Some atypical mitosis are seen in this slide. We are coming now to the type of the lung cancer that is derived from neuroendocrine cell of the lung. It's considered the most aggressive lung cancer, considered the type of the lung cancer when diagnosed the tumor already metastasized to distant organ. So the treatment of choice in such a tumor mainly chemotherapy. This type of the cancer appear as pale gray, centrally located mass, the same as we see in squamous cell carcinoma, small cell carcinoma, and squamous cell carcinoma mainly centrally located, in contrast to the adenocarcinoma, which mainly located peripherally. Small cell carcinoma extend to the lung parenchyma with early involvement of the hilar mediastinal lymph node. As we say, the tumor is derived from the neuroendocrine cell of the lung, and so they produce neuroendocrine markers that can be identified and demonstrated by immune histochemistry. And as the tumor derived from neuroendocrine cell, so we could see the paraneoplastic syndrome because of the secretion of the peptide, neuroendocrine peptide, and other protein by the tumor cell. The tumor composed of a small round cell or fusiform cell, scanty cytoplasm finely granular chromatin. Sometimes it is said it is this salt and pepper chromatin, which is a characteristic feature of a neuroendocrine cell, high mitotic figures, and the cells showing fragmentation and sometimes with smudged artifact. This is the gross appearance of centrally located small cell carcinoma of the lung with involvement, this is the bronchus, major bronchus, and with involvement of the lymph node. Actually is one of the most aggressive, highly metastatic tumor of the lung. This is histopathological examination of the tumor of a small cell carcinoma of the lung. You see that there's sheets of cells, small, fusiform, scanty cytoplasm. Here there is abnormal mitosis, which is frequently seen in the biopsy, tissue biopsy. Molding is also other characteristic feature of the cell in small cell carcinoma or in the neuroendocrine carcinoma. This is also microscopical view of the small cell carcinoma, which showing sheets and ribbon closely packed malignant cell, which is also the characteristic growth pattern of neuroendocrine type of the carcinoma. This is cytological smear of the sputum from patient with small cell carcinoma. You see the molding. You know what molding? Molding كأنه الخلايا واحدة راكبة على الثانية, showing closely packed cells. Molding كأنه واحدة مضغوطة مع الثانية, فيبين إنه واحدة كأنه راكبة مع الثانية. And also because the cells in the small cell carcinoma are fragile, so it is smudged cells or in smudged artifact cells. Crash pattern, crash كأنه crash artifact. Clinically, cancer of the lung is silent, insidious. As we say, the patient clinically may have chronic cough for a period of time, maybe months, maybe years, without appearance or without the cancer become evidence. Expectoration of the sputum, which mostly associated with blood. Sometimes hoarseness of voice, chest pain. In later stages or in advanced stages, the patient might have pericardial, pleural effusion, especially if the tumor extends to the pleura, atelectasis. If you remember, the lung collapse is one of the type of the lung collapse is when the tumor obstructs the bronchus. It might lead to the lung collapse and pneumonia. There is certain type of the tumor that arise in the apex of the lung, the upper part of the lung. It is called apical tumor, Pancoast tumor. This type of a tumor, because of its anatomical situation, it might invade the brachial plexus and cervical sympathetic plexus, which lead to severe pain in the distribution of the ulnar nerve. So sometimes those patients that has apical Pancoast tumor, they might be presented with the pain, shoulder pain, or chest pain, upper part of the chest pain, shoulder pain that radiate to the arm along the distribution of the ulnar nerve. Also, it is caused ulnar syndrome. What is ulnar syndrome? Ipsilateral endophthalmos, ptosis, meiosis, and anhidrosis. يعني يعني الجهة اللي تنضغط بالأعصاب بهذا الورم راح يصير من نفس الجهة إنه endophthalmos تدخل العين، ptosis ممكن الجفن ينزل، meiosis يتقلص لبيوبل pinpoint يسميها pupil and anhidrosis يأثر على sweat gland in this part of the in the same side of the tumor, in the tumor side, because it causes pressure on the, or it invade the nerves at this side. This tumor is called Pancoast tumor, and the combination of this clinical symptoms or syndrome is called Pancoast syndrome. The commonest tumor or the cancer that cause this type of the symptoms or this syndrome mainly located peripherally. So which type of tumor that mainly located peripherally? You can answer it. The diagnosis of lung cancer. The patient, when presented with a chronic cough, chest pain might be, productive cough, hemoptysis, pleural effusion, any of the symptoms that we mentioned, we have to do chest x-ray for the patient to identify the lesion, the type of the lesion, the location and the site of the lesion, whether hilum, at the hilum or at the periphery of the, whether there is pneumonic consolidation. So chest x-ray is very important as a primary radiological examination, which might be followed by the MRI or CT scan according to the decision of the surgeon or the general practitioner or the specialist. So sputum examination is important. 3 consecutive sputum sample should be received in order to examine the cytological feature or the appearance of the cell in the sputum. And sometimes a bronchoalveolar lavage done by the specialist, the pulmonary pathologist, the pulmonary specialist, or sometimes further, of course, to confirm the diagnosis. Of course, the radiologist would give the report that the patient has a lesion in the lung, most probably or most likely to be malignant. To confirm the diagnosis, we have to take biopsy from the lesion. So by bronchoscopy or by the open lung biopsy, according to the decision of the consultant, we get the biopsy. The biopsy examined by histopathological examination by the pathologist to confirm the diagnosis or exclude the diagnosis according to the feature that's seen in the microscopical examination of the tissue. Then we are coming to the dilemma that might be in the diagnosis of the tumor. Sometimes it's not easy to differentiate in between squamous cell carcinoma and lung adenocarcinoma. So in such a case, we have to depend on immune histochemistry. This is widely available technique, which is less challenging and can provide clinically meaningful results quickly, cost efficiently in comparison with the other techniques. This technique allows the evaluation of cellular localization of a protein in the context of a tumor structure. This is very important. This technique is very important, and it is done for every case in pathological examination to confirm the diagnosis. Because as we say that confirming the diagnosis, the type of the tumor is very important to determine the therapy or the mode of the treatment to the patient. The pathologist is required to classify lung cancer into specific subtype and assessing the biomarker which is relevant to the molecular targeted therapies. لازم ويجب أن نشخص الورم بشكل دقيق جدا, whether it is squamous cell carcinoma, adenocarcinoma, small cell carcinoma, or if we couldn't identify or demonstrate the morphological features or the immune histochemical category of these tumors, we can diagnose as large cell anaplastic carcinoma. Because this identification is very important to assess the biomarker markers that relevant to molecular targeted therapies. لأن مهم جدا بالنسبة لعلاج المريض. Immune histochemistry in the lung cancer include adenocarcinoma versus squamous cell carcinoma. Neuroendocrine markers very important to differentiate between small cell carcinoma and other types. ALK, ROS1 and EGFR, genetic markers, genetic mutations, very important for those patients. PD-L1, CD274, and to differentiate lung carcinoma versus malignant mesothelioma. Before 2015 WHO classification, the definition of the adenocarcinoma and squamous cell carcinoma based on morphological feature. That to say, the adenocarcinoma defined as the carcinoma with acinar or tubular structure, glands, glandular architecture with mucin production, while squamous cell carcinoma defined as carcinoma with keratinization, keratin pearls, and intercellular bridges. So, if we have solid carcinoma without a glandular structure, without feature of the squamous cell carcinoma like keratinization, what will we do? Basically, in the current classification, solid carcinoma without a glandular structure or mucin production, but the immune histochemical positivity showing for the adenocarcinoma, that to say TTF1 positive, napsin A positive, it is diagnosed as adenocarcinoma, even if the tumor is solid with no feature of a glandular or acinar or tubular, with or without mucin, but showing immune histochemical examination, showing positivity for the markers of adenocarcinoma like TTF1, which is NKX21, and napsin A, so it is considered as an adenocarcinoma. Similarly, if the solid carcinoma without keratinization or intercellular bridges, which is the morphological feature of the squamous cell carcinoma, here we don't have any morphological feature of squamous cell carcinoma. We have solid carcinoma, but with immunohistochemical positivity of squamous cell carcinoma as P40, CK56, and P63, all of these are positive, so we consider the tumor as squamous cell carcinoma. So the immunohistochemical staining is very important, especially for those solid tumor without morphological feature, neither of squamous cell carcinoma nor of adenocarcinoma. If the tumor is solid and we do immunohistochemical staining and reveal positive in P40, CK56, P63, so the diagnosis would be squamous cell carcinoma. This modification, when using immunohistochemical evaluation, have markedly minimized the proportion of non-small cell large cancer, which is diagnosed as large cell carcinoma. Therefore, I say that large cell carcinoma is diagnosed when we exclude other type of the cancer as squamous cell carcinoma and adenocarcinoma. By using immunohistochemical staining, we minimize the proportion of large cell carcinoma. Why? Because some of the solid cancer without morphological feature of adenocarcinoma and squamous cell carcinoma, but showing the immunohistochemical positivity for either squamous cell carcinoma, so we diagnose this tumor, which is solid without feature of squamous cell carcinoma, but showing positivity immunohistochemical positive for small cell carcinoma, that to say P40 positive or CK56, P63, all of these marker or the panel should be done for this tumor, so we diagnose as squamous cell carcinoma. But of course, it is poorly differentiated. We didn't put this in a category of large cell carcinoma because the outcome, the survival, the treatment is completely different. While in small biopsy specimen, when there is crush artifact, it is really difficult and hard to differentiate small cell carcinoma from poorly differentiated squamous cell carcinoma, with or without small cell feature or squamous cell carcinoma feature. In such a case, the marker that have been used is TTF1 and P63, and nuclear basal cell marker and a member of P53 family, which involved in the development of epithelial tissue. Small cell carcinoma predominantly showing TTF1 positive, while squamous cell carcinoma typically TTF1 negative. P63 is negative in small cell carcinoma, while positive in squamous cell carcinoma. CK5 negative in small cell carcinoma and positive in squamous cell carcinoma. CK8 positive in small cell carcinoma while negative in squamous cell carcinoma. By using this panel can differentiate between the small cell carcinoma in small biopsy with crush artifact and poorly differentiated squamous cell carcinoma. It is very important to differentiate between two because the therapeutic strategy in both is highly different. The outcome, the survival rate, the mode of treatment, the prognosis, all of these are different in between two, so we have to differentiate these two tumors in small biopsy specimens. Genetic mutation and testing in lung cancer. Lung cancer is considered one of the cancer that has genetic mutation in the form of somatic mutation. There is mutation in the genes that control cell growth, division, proliferation, or the gene that responsible of the repair of damaged DNA. So when there is genetic mutation, the changes render the cell to grow and divide in uncontrolled manner or in a controlled way. So it will lead to development of the tumor. According to the published papers, nearly all cases of the lung cancer show sort of genetic changes which might be acquired during a person's lifetime, and they are present only in certain cells in the lung, not all cells, and it is not inherited. They are acquired changes. These changes are called somatic mutations. Somatic mutation in many different genes have been found in lung cancer. Sometimes, in rare cases, the genetic changes is inherited. In such a case, it is present in all body cells, not on certain cells, which is seen in somatic mutation. No, here it is present in all body cell, and it is called germline mutations because it is inherited. The genes that underwent somatic mutation in lung cancer include p53, which you know that it is tumor suppressor gene, epidermal growth factor receptor gene, EGFR, KRAS gene. Those are commonly seen in lung cancer. EGFR, the gene that produces protein, which is called epidermal growth factor receptor, is abnormal, the protein that produced by this mutated gene. Seen in about 10% of patients with non-small cell cancer and in about 50% of the lung cancer which arising in the patient who have never smoked. Those patients or those tumors are most commonly adenocarcinoma, which show EGFR mutated gene. So those patients with cancer that has EGFR mutation respond positively to treatment. Drug of choice in those patients is erlotinib or Tarceva. This is a trade name of the drug, which are the drug of choice on those patients which show EGFR mutation positive. The doctor recommend the treatment with this drug or participation in a clinical trial with other drug in order to give chance to the patient because has mutation in GFR. So the drug of choice against this type of the receptor or mutated gene is present, as exists in the market. So why the doctor does not use it? So they use it in those group of patients. Another mutation we regularly test for is a gene in KRAS. Also, this KRAS mutated in about 25% of patients with non-small cell cancer. So if the tumor tested for the mutation in KRAS, the doctor also recommend a certain type of the drug that is targeted against this mutated gene. We are now coming to the small cell lung cancer. The gene mutation in such group of lung cancer, which is considered as the most aggressive, high-grade subtype of lung cancer with low survival. In one of the papers that published in 2016, the survival rate is below less than 7%. We consider that the standard treatment have not changed in decades because the biological behavior of such type of cancer is different from the other type, and it is sorted in one category. There should be a deep understanding of the cellular and molecular mechanism that underlying the initiation and the progression and metastasis acquisition of resistance to the treatment in such a type of the lung cancer. All of this is required in order to improve the treatment of choice with targeted to this type of cancer, because the prognosis in such cancer is gloomy and is very bad prognosis. And as we say that the survival, 5-year survival is less than 7% in the I think is in the published paper in 2016. So we have to study very well the initiation and progression and the metastasis of this type of the cancer, small cell carcinoma of the lung. Deep understanding to the cellular and molecular behavior and the mechanism of such type of the tumor. Also, in such type of tumor, there is certain mutated gene that is found in such a group of tumors. Extensive gene analysis that carried out showing there's panel of gene that appear to be abnormal or mutated in such a group of tumor or cancer. And it's almost seen in nearly all small cell lung cancer, such as P53, it is tumor suppressor gene, retinoblastoma gene, RB, so other tumor suppressor gene, Mike family members. In addition, we have seen that oncogene mutation as KRAS that is seen in non-small lung cancer, we discussed in the previous slides, are rare in small cell carcinoma or not existent. So the drugs that are used in the other group of the cancer or other category of the cancer that we found that there is a mutation in KRAS, here cannot be used. The predominant mutation that observed and carried out in small cell lung cancer include loss of function mutation in RB and P53 gene. These are tumor suppressor genes. So loss or mutation in such a gene, loss of the function, because these genes are tumor suppressor gene. The guardian of the genome P53 gene is the guardian of the genome. So when loss of the function or there is mutation in such a genes, it will lead to the development of cancer, as in small cell lung cancer. Overexpression also of a proto-oncogene by amplification of chromosomal region include L-mic or C-mic are also seen in small cell carcinoma or small cell lung cancer. Now we are coming to the paraneoplastic syndromes. What does the mean of paraneoplastic syndromes? These group of symptoms or biological changes that occurs in the certain type of the cancer, including lung cancer, as in squamous cell carcinoma, small cell carcinoma, adenocarcinoma of the lung. Is paraneoplastic syndrome could be seen in other cancer in the body? Yeah. Can be seen in other type of the cancer, as in the pancreatic carcinoma, in the breast cancer, and other type of the cancer out of our scope here. But it is common in the paraneoplastic, is common in lung cancer? Yes. It's constituted about 3% to the 10% of the patient with lung cancer develop clinically overt paraneoplastic syndrome. What are these syndromes? First, which is the most important, is hypercalcemia. The level of the calcium patient with cancer is due to increased PTH by squamous cell carcinoma. Squamous cell carcinoma produce PT elaborate parathyroid hormone. Parathyroid hormone normally secreted by the parathyroid gland. But here, squamous cell carcinoma elaborate this type of the hormone, which lead to the increase in the level of the calcium. In sometimes squamous cell ACTH, which is normally secreted by or elaborated by the adrenal gland. But here, squamous cell carcinoma might elaborate this type of hormone. ADH also, which is secreted by pituitary, can be secreted by the squamous cell carcinoma. So the biological behavior of the tumor is really variable. 3% to 10% of the patient, not all patient, 3 to 10% presented with paraneoplastic syndrome. Neuromuscular syndrome as myasthenia gravis, peripheral neuropathy, poliomyositis might be seen in lung cancer. Clubbing finger, hypertrophic pulmonary osteoarthropathy, migratory thrombophlebitis, inflammation of the vein, can be seen in adenocarcinoma. We are done with the lung cancer. We try to cover the most important aspect in lung cancer, actually the type, the genetic mutation, which is very important. How to differentiate in between small cell carcinoma and polydifferentiated squamous cell carcinoma, the presentation of each, the most common type, the latest bronchoalveolar carcinoma, what is the latest information or the latest introduction of a newly type of adenocarcinoma, like lipidic type adenocarcinoma and minimally invasive adenocarcinoma, and in situ adenocarcinoma, in which it is previously known as bronchoalveolar carcinoma. Now no more use this term we replace it by adenocarcinoma in situ. So we tried to cover all these topics. We are now coming to the certain type of the tumor that might develop and occurs in the lung, which bronchial carcinoid. Actually, the carcinoid is a tumor that might occur or develop in any organ of the body, in any organ, especially the organ that contain or arise from the neuroendocrine cell, or it is called Kalchisky cells. Here, bronchial carcinoid, it is constitute 5% of the lung tumor. The characteristic feature of the neoplastic cell contain dense core neurosecretory granule in the cytoplasm. This is the characteristic feature of the neuroendocrine tumor in general, including the small cell carcinoma, if you remember. It is also arising from it, but this is malignant extreme. In the malignant extreme, small cell carcinoma. Here, bronchial carcinoma, it is benign, considered to be benign. However, sometimes locally metastasized to the lymph node. The biological behavior of the carcinoma is different, but it is better prognosis, of course, better prognosis than small cell carcinoma, for sure. May part of multiple endocrine neoplasia syndrome, when there is gene mutation insert this type of gene, to have more than one organ involved in such a syndrome. This carcinoid appear early in the age of 40 years, resectable and curable. 5 to 15% give metastasis to the hilar lymph node and rarely metastasize to the distant organ. Usually it arises in the main bronchus, may enlarge, grow and enlarge in size and cause pulpoid lesion that obstruct the bronchial wall, sometimes extend into the peribronchial tissue. It looks like collar button lesion, مثل زرار القميص. Collar button. This is the gross appearance of the تشبه زرار القميص. Collar button appearance. This is endoscopy view of bronchial carcinoid polypoid lesion, like polyp, to include the lumen. This is microscopical view of the carcinoid tumor, looking like nesting sheets of uniform looking cell, regular, nuclei, round, stippled chromatin. If you focus here, you see that chromatin is stippled like salt and pepper, which is a characteristic feature of neuroendocrine tumors in general. Should make rosetting. This is also the feature of a neuroendocrine tumor. Electron microscope showing neurosecretory granules. This is neurosecretory granules, which is also the characteristic, as we say, the feature of the carcinoid. Pleural lesions and mesothelioma, pleural tumor, and laryngeal tumors. The last two topics that we will cover in respiratory module pathology. First, pleural effusion. All of us, we know that if there is fluid in the pleural space, it is called hydrothorax, can be transudate, the specific gravity is low, as in congestive heart failure, or might be exudate with high inflammatory, infiltrate in it with high specific gravity. Even the color is dark color than the transudate. This can be seen in pleuritis. In pyemia, when there is pus accumulate in the pleural space. Pneumothorax is air in the pleural space. Chylothorax is accumulation of the thick white milky fluid, that to say lymph, especially when there is rupture of the lymphatic duct. When there is blood accumulate as a result of the trauma, as example, or fracture of the rib, hemothorax, or sometimes seen in the malignant tumor or during surgery, it is called hemothorax. This is a diagram that showing the fluid in the pleural cavity. And if we remember and back to memorize the collapse of the lung, one type of the collapse of the lung is due to the pleural effusion, if it persists for a long time without treatment. This is blood, it is hemorrhagic, pleural effusion, fresh blood in the pleural cavity, which cause lung collapse. Other cause of the lung collapse when accumulation of the fluid or blood in the pleural cavity. Malignant mesothelioma. Actually, this is rare carcinoma of mesothelial cell. It is rare in our country here, or rare in certain countries, but actually it is one of the common carcinoma in Egypt. For uncertain reason, actually, no one knows, because you know that mesothelioma is more common among asbestos patients. Anyway, it's one of the rare cancer of the mesothelial cells. It arises in the visceral pleura or in the parietal pleura. Also might arise in the pericardium and peritoneum, because also lined by the mesothelial cell. As we said, and as we know, it is related to the occupational exposure to the asbestos. In 50% of the patient with this tumor, there is relation with the occupational exposure to the asbestos. In miner, insulators, shipyard workers, all of these are exposed to the asbestos. Morphology. The tumor enshits the pleura، يحيط بالبلورا كلها، which cause diffuse thickening of the pleura. It might preceded by progressive pleural fibrosis or pleural plaque formation, which is also one of the complications or consequence of asbestosis. Histologically, there is three forms, either epithelial, which showing glandular structure, or sarcomatous, which consists of the malignant spindle cells, or there is the tumor composed of both elements, epithelial and sarcomatous elements, or malignant spindle cells. This is the tumor, and this is the lung, and this is the tumor, enshitting, thickening and enshitting the whole lung. كأنه محاطة. This is a malignant mesothelioma. This is a microscopical view of the epithelial type. This is the epithelial type of the mesothelioma. And this is the sarcomatous spindle cell. Look, spindle cell look like smooth muscle cell, but it's spindle cell and it is malignant cell. There are many criteria that included in the diagnosis of this tumor. We are coming now to the type of the cancer that arise in the nasopharynx, nasopharyngeal carcinoma. This type of tumor has a strong epidemiologic link to the Epstein-Barr virus. This type of the cancer among the types of the cancer that, like lymphoma, which will be discussed and will be covered in HLS system, which is closely related to Epstein-Barr virus infection. High frequency among Chinese people, has three histological features: keratinizing squamous cell carcinoma, non-keratinizing squamous cell carcinoma, and undifferentiated carcinoma. This undifferentiated carcinoma most common and closely related to Epstein-Barr virus infection. Histological appearance of the tumor showing striking influx of T lymphocyte surrounding sheets of malignant epithelial cells. Therefore, has another name which is lymphoepithelioma. This type of cancer is radiosensitive and the 5-year survival is 50%. This is a microscopical view of nasopharyngeal carcinoma. Look at the T lymphocyte, mature T lymphocyte. It's not malignant. This sheets of malignant cell, epithelial cell, syncytial sheets of malignant cell surrounded by mature lymphocyte. So the malignant component of the tumor is not the lymphocyte, it is the malignant epithelial cell. This is tumor called lymphoepithelioma. Now we are starting with the laryngeal tumors, benign tumors, which include vocal cord nodule or polyp. Actually, this type of tumor appears or look smooth, hemispherical protrusion, less than 0.5 centimeter, located in the true vocal cord. Therefore, those patients that have this nodule complaining of changes in their voice, sometimes due to the irritation which caused by this nodule to the vocal cord, those patients, most of them, that they are using their voice, as in the singers, smokers also, this nodule might be found in the smoker patient because it irritates the vocal cord, and also in the teachers, because the teachers and that always talk a lot and in order to give the information into their student. So I hope this nodule is not present in our vocal cord. So the nodule is covered by stratified squamous epithelium that is usually intact, but sometimes it ulcerates. So the benign tumor or the nodule that is found in the vocal cord in smokers, singers, teachers, or patients, or people that are using their voice is a vocal cord nodule. Look at it. Here, gross appearance of this vocal cord or laryngeal nodule. It is actually bilateral nodule. Here appear on both vocal cord. This is an endoscopic view of the larynx. This is a microscopic view of the benign laryngeal polyp, or also called Singer nodule. It's showing loose fibrous stroma. This is a fibrous tissue fibrous stroma, loose fibrous stroma. This is blood vessels, or this is a blood vessel, and this is a loose fibrous stroma covered by normal squamous epithelium. This is a laryngeal nodule, as simple as such. Loose fibrous stroma or connective tissue covered by the benign normal looking squamous epithelial cell. The other type of the benign tumor that arise and develop in the vocal cord is a laryngeal papilloma. It is squamous papilloma, benign neoplasm, where it appears usually on the true vocal cord that form single nodule, soft, raspberry-like excrescence or pulp-like, rarely more than 1 centimeter. It's usually 1 centimeter and less than 1 centimeter. Histologically, it's multiple slender-like projection, like any papilloma end of the body. Finger-like projections of the fibrovascular cord covered by the epithelium, stratified squamous epithelium. This is the histological appearance of laryngeal papilloma. Multiple finger-like projection as any type of the papilloma that we have seen in other tissue or in the other organ of the body, as in the skin. This finger-like projection is supported by fibrovascular cord, which covered by squamous epithelium. In children, there is multiple papillomatous lesions that sometimes tend to recur even after excision. This is the papillomatosis, or the laryngeal multiple papillomatosis. Look at here. This is the endoscopic view of the larynx, showing multiple papillomatosis, which tend to recur after excision. These lesions caused by human papillomavirus type 6 and 11. As I think we have had many types of the lesion, actually benign lesion like skin papilloma that caused by the human papillomavirus type 6 and 11. It does not become malignant and regress after puberty in case of the multiple papillomatosis that occurs in the children. Sometimes this type of the papillomatosis probably it's vertical transmission. That means the patient got the virus from his mother during delivery, especially if it's normal vaginal delivery. Therefore, recent availability of human papilloma vaccine is very important to protect women during reproductive age against certain types of the tumor of human papillomavirus types 6 and 11, in order to prevent development of this papillomatosis in the children. We start now with discussion of carcinoma of the larynx. Carcinoma of the larynx is type of the cancer that constitute about 2% of all cancers. Most commonly develop after the age of 40, more common in male than female, in a ratio about 7:1. So it's more common in men. Actually, the ratio is high. Nearly all cases are smokers, but this does not mean that all smokers develop carcinoma of larynx like lung cancer. You know, almost most of the cases are smoker. However, not all smoker cases or smoker patient or lead or develop CA larynx. Also more in alcoholic, and also asbestos exposure might increase the incidence of carcinoma of the larynx. The most common type of the carcinoma of the larynx is squamous cell carcinoma, 95%. Rarely adenocarcinoma. It develops from true vocal cord, it is a glottic tumor, which is constitute about 60–75%. This is the most common type of the laryngeal cancer. Supraglottic tumor, about 25–40%, while subglottic it's only 5%. So the most commonly develop directly on the true vocal cord, which is called glottic tumors. Human papillomavirus detected in a few cases. Squamous cell carcinoma grossly appear or begins as gray plaque on the mucosal surface, or sometimes mass, sometimes fungating mass, sometimes ulcerating mass on the surface, mucosal surface of the larynx. The type of the glottic tumor, generally keratinizing squamous cell carcinoma, and the adjacent mucosa showing dysplasia and carcinoma in situ changes. These changes especially occurs and seen in a smoker patient, because smoker patient, the smoke irritate the mucosa and change the mucosa, and the underlying epithelium undergo or showing dysplasia, dysplastic changes, and carcinoma in situ, and subsequently as squamous cell carcinoma develop. This is a gross appearance of invasive supraglottic. This is a glottic, this is a vocal cord, and this is a glottic supraglottic type of squamous cell carcinoma. This is a supraglottic squamous cell carcinoma of the larynx. This is the glottic, this is supraglottic type. Look at the mass, plaque-like mass lesion, ulcerating. Look at the ulcerating surface, mucosal surface. This is a typical well-differentiated keratinizing, well-differentiated squamous cell carcinoma. This can be seen in this picture. It is really educational, and it is typical picture of squamous cell carcinoma, well-differentiated, because we can recognize the type of the epithelium or the type of the malignant cell, which is a well-differentiated squamous cell epithelium, and this is the keratin pearls. Look at the keratin pearls that are represented. This is very actually, it's a very beautiful picture which represents the squamous cell carcinoma. You can print it in your mind that this is the typical picture of well-differentiated squamous cell carcinoma, including the keratin pearls and look at the intercellular bridge between the epithelial cell. And this is the keratin pearls. Clinically, the patient with carcinoma of the larynx presented with hoarseness of voice. What I mean of the hoarseness of voice, meaning the change of the voice of the patient. The patient recognized that his voice is changed without any explanation for these changes. That patient that does not have any infection or inflammation or tonsillitis or laryngitis, but his voice is already changed, and he complaining of this, the chief complaint of the patient, when he presented to the the ENT doctor, he told him that my voice is changed. It is the earliest symptom actually of the glottic cancer. 90% of the glottic cancer are confined to the larynx at the time of the diagnosis. Therefore, the glottic tumors are better prognosis than other type of the tumor in other location of the larynx. Spread beyond the larynx is uncommon because of the spurs of the lymphatic supply. Subglottic cancer are clinically silent, so the presentation of the patient, usually patient presented in advanced disease. The other clinical feature that the patient might present with the carcinoma of the larynx, might patient cough because irritating. This mass might irritate the larynx, so the patient have cough, sometimes with the bloody streaks of sputum, like patient come to say that I'm coughing with streaks of blood because of the ulceration, sometimes pain, especially if the tumor is ulcerating and invading underlying structures or surrounding structures. Sometimes patient presented with the suffocation or feeling on the lump in his neck or throat. He say that I have أنا مخنوق يعني أنا مخنوق أحس I feel something here in my throat. And if the tumor metastasize or spread to the lymph node, the patient might present it with cervical swelling or cervical lymph node enlargement. And this is presentation of one of the patient that I know. Patient presented just with cervical or lymph node enlargement. The lymph node was hard, large and hard in consistency, and so the patient, when presented with this presentation or with this complaint, when he examined thoroughly, they found that he has carcinoma of the larynx. There are certain prognostic and predictive factors of the laryngeal cancer. As any type of cancer, the stage is the most important prognostic and predictive factor. The stage of laryngeal cancer includes size of the tumor and how far it has grown into other tissue around the larynx or invading the underlying structures, especially the neck include many vital structures that surrounding the larynx. Of course, the earlier stage cancer, localized cancer, especially in the glottic type, which 90% of them are confined to the glottis or to the vocal cord at the time of the diagnosis, have better prognosis than that diagnosed at later stage. Location of tumor, as we say, that glottis tumor that in the true vocal cord has better prognosis than subglottis, and the cancer start elsewhere in the larynx, spreading to the lymph node, because you know the lymph node is very important in the staging of the tumor. Therefore, spreading to the lymph node is very important as a prognostic and predictive factor. Cancer that are confined to the larynx without spreading to the lymph node in the neck surely has better prognosis than the cancer that spread. And of course, the prognosis is better if the lymph node with the cancer are small, and if the cancer has spread to the lymph node on only one side of the neck, not in both sides of the neck. There are many factors contribute to the prognosis, to determine the prognosis of the cancer in the larynx. Depth of the tumor growth. Tumors that grow inward and deep into the tissue of the larynx and neck have, of course, poor prognosis than a tumor grow along the surface of the larynx, because deeper the depth of the tumor, deeper how deep the tumor grow, that means it invade the surrounding structures. While that grow along the surface, it means that it is remain the staging of the tumor is still in early stages. The general health of the patient also is very important, include performance status, nutritional status, how well the function of the lung doing, and other health problem that really affect how well the patient will cope the treatment for cancer of the larynx.